Okay, I want to welcome all of you on Zoom and here in person to our seminar. Today, our speaker is MEHMET Cilingiroglu. Did I say that right?
Thank you. Perfect.
So, MEHMET and I actually have known each other for many years. He started MEHMET in Austin, Texas. MEHMET was doing work with Dr. Feldman in San Antonio, and we were just starting to work on OCT. And MEHMET has been working in OCT and cardiology now for 20 years about it, and very familiar with all the different devices that are used in interventional cardiology, atherectomy devices, and so on. And more recently, MEHMET's been working with the MD Anderson Cancer Center, doing OCT in cancer patients. So these are the two biggest challenges we face as humans: cardiovascular disease and cancer. They take more of us down than anything else. So we're excited to hear that.
Thank you. Thank you so much, Tom. It's an honor to be invited here. I live in San Diego and love California. And after I moved here with my wife and kids, I was very excited for Tom's move to Laser Institute. And thank you for your invitation again. And it is a pleasure to meet with all of you. So today I'm going to talk to you about cancer and in cancer patients, the cardiovascular problems that we face. And it is a new paradigm and subspecialty of cardiology. So when we talk about this, we have certain outlines that we want to see: mechanism of cardiac toxicity in cancer patients. These are specific really to the cancer patients. Acute coronary syndromes, meaning the coronary artery disease turning into the heart attack in these patients in various forms. Special considerations in the cath lab for the specific populations, and challenges both from the clinical standpoint and the cancer standpoint. How do we optimize the TCI in these patients? Why do we use in every single patient intravascular optical coherence tomography and special procedures in cancer patients? So when we look at the cancer patients, about 1 in 150 patients walking on the population, walking on the street, actually is a cancer survivor. As compared to 2 decades ago, the treatment paradigms change and new treatment modalities, both in chemotherapy, radiation, specific radiation, and as well as immunotherapy, change the patient's survival, and the patients basically is surviving longer, and the patients with cancer in general population is continuously increasing. So 14.5 million cancer survivors, expected to increase to 20 million by 2020. It is going to be doubling by 2030. Cancer patients have excluded specifically from most PCI. PCI stands for percutaneous interventions, registries, and randomized clinical trials, and actually from many non-cancer heart studies, because of obvious reasons. When we look at these patients and the vasculature and the heart, we can see that the vasculature is exposed to multiple pathophysiologic processes by chemotherapy, by the cancer itself, and the radiation therapy, besides the conventional risk factors such as diabetes, smoking, and etc. We have a research proposal. So what happens is those patients, they basically get radiation. Radiation causes the oxidative stress that we all know, and through the activation of the NF-kappa B pathway, an inflammatory process gets started in the vascular wall, and then eventually leading into napkin ring pathology that we see in this patient, such as in this right coronary artery. You can see that there is an osteo disease from the radiation itself. So 50% of cancer patients do receive still radiation therapy, Some of them, as you know, specific to the area rather than in general. So mostly we worry about the right-sided, especially breast cancer patients, right-sided radiation causing into left main disease. It is the oxidative stress and inflammation, cholesterol plaque formation, thrombosis can appear within few days on these patients. Then mostly is the fibrosis in all layers of the vessel wall leading into neck and ring lesions. Radiation-induced coronary toxicity, as we can see, it can be different, but mostly the type that we see is left main stenosis. These patients basically die mostly on treadmill, including some of the interventional cardiologists who do a lot of peripheral work because we get such amount of radiation, and then we end up basically dying sometimes on treadmill. So extensive mental radiation for Hodgkin lymphoma patients and esophageal cancer patients, osteal and multiple vessel stenosis that we see in these patients. It may take some time, about 10 years after radiation therapy for Hodgkin's disease, lymphoma, severe stenosis of the left main that you can see right up here and right up here. And osteum in 30%, they usually do not have any symptom, and the first symptom is sudden cardiac death. So for that reason, radiation has been changed, and focal radiation, such as breast cancer, that can cause focal disease instead of left main disease in patients, and it is usually the fibrosis, as you can see in this LAD, or diffuse disease you can see in these patients, even though you try to aim the radiation to the specific area. And when we saw those statin medications that we take for cholesterol, do they prevent you from oxidative stress that is induced by radiation? The answer seems to be yes. So studies have been shown that in cancer patients, we know they will develop coronary artery disease. They do have conventional risk factors. We go ahead and start them on statin therapy, and through the NF-kappa B pathway blockage, they can basically prevent the fibrosis and the initiation of the cascade on the vascular inflammation and stenosis and fibrosis in these patients. So we came up with a research idea with University of Hawaii, where I also provide some services and teaching and research, basically that should we basically put these patients, since they do have oxidative stress, maybe the hyperbaric oxygen chamber before they go into the radiation therapy. So the research is ongoing, and we will have an answer for that. So the radiation, chemotherapy, and immunotherapy does affect all the systems, the whole vasculature, and creates different pathologies, including the valvular heart disease. So the specific agents, basically in 2000, year 2000, me and Andy Anderson, the catheter director, Dr. Iliescu, basically, and Dr. Marmagiolis get together and said, we need to basically look at this specific population, what they are taking and what kind of side effects they have. I am not expecting you to memorize all this, and we don't memorize, we have a list. But you can see that different common chemotherapeutic agents leading into different pathologies in both heart as well as the entire vasculature, such as 5-fluorouracil that we use in colon cancer, cause vasospasm, MI, Takotsubo, cardiomyopathy, and many others. So chemotherapy-induced vascular toxicity is a new thing that initiated maybe 10 years ago. We didn't know anything about that. Does the cancer agents cause any kind of pathology in the vascular wall? As I said, 5-fluorouracil, abnormal vasoreactivity, and not transient. Necessarily, the more they expose, that becomes permanent. Severe vasospasm resulting in ACS, that is paclitaxel, the breast cancer medication, and docetaxel. I'm not, again, expecting you to remember this, but one of the patients that we had, my patient, she was a nurse practitioner in the emergency room. I will show you her pictures. If you basically have repetitive injury into the vessel wall with vascular spasm, they end up developing cardiomyopathy. Acute coronary thrombosis, even in multiple territories at the same time, that is cisplatin, that is being used in bladder cancer. And endothelial dysfunction, bleomycin, that is also another chemotherapeutic agent. And some of this endothelial dysfunction is permanent. If you do body mass chamber, basically use the reactivity with the blood pressure machine and inflate it about the systolic and then release it, you have this sudden vasodilatation that gets impaired in these patients on a permanent basis, meaning 10 years after the chemotherapy. And then transmetal angina, which is the vasospasm at the moment of the event, and this is with cyclophosphamide that is being used in bladder cancer. Accelerated atherosclerosis, also initiated with these agents, and Takotsubo cardiomyopathy. Now, when you have Takotsubo cardiomyopathy, is it the stress from the patient's cancer, constant thinking, constant dyspnea, etc., versus the chemotherapeutic agents have been studied, and actually chemotherapeutic agents do cause reversible cardiomyopathy called Takotsubo cardiomyopathy or stress-induced cardiomyopathy. Now, the cancer effects that requires PCI, percutaneous intervention. The cancer itself, spontaneous coronary artery thrombosis, because the cancer itself provokes the thrombotic event through multiple pathways. Malignant coronary embolism, either myxoma or lung cancer that can embolize to the coronary arteries, and external coronary compression, especially left atrial cancers, like in angiosarcoma in the left atrium. I had a patient 2 weeks ago in Texas. Basically, the gentleman had a tricuspid valve replacement and bioprosthetic, and he had a right axial angiosarcoma, and the entire tricuspid valve was occluded, and he was hypotensive because there is no preload, and he unfortunately died in a few days. He was an elderly man. So there are different ways that can cause the problems in the cardiovascular system and the invasion of coronaries by angiosarcoma itself. Now, the acute coronary syndromes, these patients do develop heart attacks. If you look at them, these patients live longer. The longer they live, they have the conventional risk factors that we all have. And then basically on top of that, they have radiation and stuff. So the patients are living longer and they ending up with STEMI itself. More patients we see. So cancer centers now has cardio-oncology department, and the specific cardiologists, interventional cardiologists, they are very experienced in taking care of these patients. So when we look at the silent ACS in these patients, meaning 50% of the heart attacks in the usual population as well has absolutely no symptoms. Some of these patients come in, you do the echocardiogram, they are 45 years old, the ejection fraction, meaning the pumping function of the heart, is severely reduced. You ask them, did you have any heart attack? They say no. You look at their EKG, indeed they did. So the symptoms are conventional symptoms, chest pain, dyspnea, and hypotension in these patients. And if you look at the medical therapy on these patients, ST elevation, non-ST elevation, I don't want to get into medical technical terms on these patients, is basically intervention makes a big time change. So medical therapy itself is not good enough because of multiple reasons. These patients, even if you put stents in them, they have predisposition to thrombus formation immediately inside the stent, again, because they have more thrombogenic media. So as you can see here, catheter-based therapy makes a huge difference in these patients. You want to take out the clot and you want to basically put a stent, but you want to make sure that stent is very, very well expanded. And that's why we use in every single patient OCT, intravascular OCT. Relationship between the cancer and cardiovascular outcomes based on the percutaneous intervention, they are exactly parallel to the normal population, meaning that they are as effective, not less effective, as in the normal population. Retrospective studies at Duke University has been shown between 1996 and 2010, and PCI in all patients, all comers, when you look at them, 496 patients have history of cancer. When you look at them, they are absolutely overlapped with the patients which are who do not have any cancer. meaning that you having cancer does not basically put you in a downgraded or percutaneous intervention. You have to open the vessel when the vessel is occluded, and you have to image it and see if it is a plaque erosion versus plaque rupture, because we want to treat them differently. 60% of ACS patients in cancer patients are silent because they do not have the normal regulatory pathways that they get a chest pain, especially women, especially in female. Anything above the belly button, basically any sign can be the signs of mortality, ACS in these patients. Medical therapy alone yields 1-year mortality of 74%. That is very, very high. So we want to definitely treat these patients. Primary PCR for cancer patients with stem results twofold increased mortality. So we really, really want to treat them. Again, this is a patient, a 78-year-old, he had a heart attack. Should we really treat this patient, or should we let this patient die because he has underlying cancer? The answer is we want to treat these patients as long as they have more than 6 months survival. Data about the non-emergent PCI in cancer patients is discrepant. That is at the time of this presentation. But the more data we have a huge database. We have almost like 1 million patients with cancer at MD Anderson. So the data looks like very promising. Elective PCI is changing the lifestyle. So first time we basically Society of Coronary Angiography and Intervention. I was honored to be one of the members, basically writing this guideline statement for how we manage patients with cardio-oncology because the population are increasing. Safety of diagnostic and therapeutic catheterization in cancer patients, when we look at them, they have a problem. They are anemic and they have their platelet count down. So will you be able to do all this procedure, diagnostic and interventional, with their platelet count being down? We didn't know that 20 years ago, but now we know that as long as your platelet count is around 5,000, yes, we can do diagnostic, and we usually do it from your wrist instead of doing through the groin for obvious reasons. We don't want you to bleed, but we basically can do successfully without you bleeding into your brain or anywhere else as we do the intervention and give you blood thinners. There is not a low platelet threshold for coronary angiogram. We used to think that these patients should not be treated. We were afraid they will have problems. You can't do OCT imaging because when you do OCT imaging plus the intervention, you have to give heparin. So there is no threshold, low threshold, that we basically cannot do the OCT imaging and the intervention in these patients. We look at that the survival of these patients should be more than 1 year, 6 months to 1 year. So PCR should only be done for STEMI patients and for high-risk non-STEMI patients. STEMI patient is the plaque rupture and occlusion of the vessel wall, like in a dog model, and then you basically have ST elevation. There is no flow. You have to use stents to open that artery up, sometimes thrombus aspiration. But non-STEMI patients are plaque erosion. So you have some blood flow, but you have plaque erosion, and the difference in between you will be able to see when you use OCT. So we use OCT in every single cancer patient that we do have. We want to understand the pathophysiology, what is the underlying pathophysiology, so that we can treat them accordingly. With chemotherapy, dual antiplatelet therapy, meaning aspirin, Plavix, or aspirin, ticagrelor, may need to be extended due to delayed endothelialization of the stent. So we basically use the OCT when these cancer patients, breast cancer and others, we work with oncologists very, very closely, and we put the patient right at the center, and we basically look at the OCT if there is a good stent expansion, and then if there is basically tissue healing over the stent, we basically go ahead and stop or do antiplatelet therapy so that patient doesn't have to be at the bleeding risk, and they can have their biopsies and surgeries, the therapies that they need. We do not use the femoral preferred line on these patients. We use the radial more, but if we use the femoral, we want to make sure that we just access the vessel right in the optimal area. We use micropuncture, we use the radiation, because we want to enter the vessel above the bifurcation, but below the interepigastric artery, so that they don't have fistulas, they don't have retroperitoneal bleed. So we are very tedious about how we reach these patients and how we do. Most of the time, radial access. And then dialysis and the other patients, and then bilateral mastectomy patients have when we basically plan an extra step. Sky documentation stated for the first time, aspirin only when platelet count is above 10,000 for these patients, aspirin only. And then dual antiplatelet therapy when they do have the platelet count is 30,000 and above. So these are very, very important and specific to these patients. 30 to 50 units per kilogram unfractionated heparin is recommended when their basic platelet count is less than 50,000 and you want to use the OCT for these patients. We recommend against the use of other high-risk bleeding agents in these patients when their platelet count is less than 50,000. So there is challenges for cancer patients. Number one, the need for premature dual antiplatelet therapy discontinuation. This is what we use the OCT for in every single patient. We don't use IVs. We use the OCT because we believe in OCT. We make sure that stent is number one. We evaluate the lesion well. Number two, we make sure that stent is well expanded, correct size. There is no stent malposition, either early or late. And we look at that, and then we can discontinue all patients on their dual antiplatelet therapy instead of conventional 6 months to 1 year. Invasive evaluation of patients with severe anemia and thrombocytopenia, no problems, no adverse effects. We learn it with the use of the OCT, and we learn it by doing it on the patients, cancer patients. And the novel mechanisms of ACA, we also able to learn this with the use of OCT. Major challenges for cancer patients, they need to drop the platelet therapy earlier than 1 year, and then basically, and when you look at here, antiplatelet consideration in post-PI registry in non-cardiac patients, non-cardiac surgery patients. So we were able to develop an algorithm, and we share this basically now it is published that you can basically discontinue the antiplatelet therapy even after 1 month if you have a good OCT evaluation of the vessel after the stent deployment, basically using OCT imaging. I'm going to pass that one. This is not, this is medically relevant. Basically, small molecules we use occasionally if we need to basically do an intervention. We don't want a long-acting molecules intravenously in this patient. So acute and stable ischemic heart disease, when you look at them in every single one of them after the infarction, basically the intervention makes a huge difference, meaning that open the artery as early as possible. So this is the article that we have published, bridging the light on in a complex scenario of OCT use guided discontinuation of optical coherence tomography. Tom is one of the authors as well, and Mark Feldman. This is the Protect OCT registry. So what we find out is as long as you have a good coverage, you can see that very nice coverage of tissue on OCT. This is the stent struts, and this is very, very nice healed up tissue. This patient we can discontinue, go ahead and discontinue the dual antiplatelet therapy by use of OCT. So when you, and in high-risk patients, that is very important. So if you look at the challenges in cancer patients, we do in every single patient. We never do it based on angiogram. Is OCT needed for all cancer patients who need to start the dual antiplatelet therapy? Our answer is yes, because we love OCT, we believe in OCT, and we believe what we see. Which is the preferred bridging agent? Small molecules of the subject. Either you can use this, but most of the time you have to use, never use, so this is very important for your personal safety. If you have stents, and some of you may have, if somebody says, we will stop your dual antiplatelet agent, and then we will give you heparin, tell them no. Heparin and Plavix are different agents. One is anticoagulant, one is antiplatelet. One is white clot platelet, the other one is a red clot, which you can differentiate with OCT. So please don't ever let somebody to put you on heparin when you have stent just to bridge and discontinue. You will have stent thrombosis, I guarantee you 100%. And I saw it actually on a patient who had a carotid stent. Novel mechanisms, as I told you, cancer patients with thrombocytopenia is a big deal. So we have learned that as long as you have some platelets, we can get away with that. No problem with PCI or use of OCT. Safety of diagnostic and therapeutic catheterization cancer patients with acute coronary syndromes and thrombocytopenia. You can see that as compared to, what is the message here? The message is, as compared to patients who have normal platelet count, the cancer patients with low platelet count, there is no difference in regards to the MACE outcomes, bleeding, stroke, etc. So consensus determinant is going to be rewritten in the next year or so. We are working on that, but we have learned this thing. Use aspirin if your platelet count is about 10,000. Use Plavix dual platelet if your platelet count is about 30,000, okay? And other challenges, Plavix safely discontinued when your platelet count is less than 30,000 after PCI. The answer is yes. Could aspirin discontinued when your platelet count is less than 10,000? We usually continue that because there is not much bleeding, but we communicate with our oncologists one-on-one. So the patient is at the center. We make sure that patient is taken care from the standpoint of cancer and the heart. Should the platelets have been transfused to patients so that we don't make them bleed? We will use OCT, we have to give heparin. The answer is no. All these platelets go and stick on the freshly implanted stent, which has not had a chance to heal up yet. So you will provoke stent thrombosis. Don't give them more thrombocytes. Novel mechanism of ACS. There are different reasons why they embolize. You can see right here, different embolization is one, arterial myxoma is another one, etc. Hyperthrombogenic state is another one. Radiation and napkin ring lesions is another one. How many of the STEMIs in cancer patients are due to malignant embolism? Should aspiration thromboectomy be used more often? The answer is yes, yes. And then should aspirated debris stent for pathology? The answer is yes, because some of this is clot, some of this is cancer. So stent-induced, stress-induced cardiomyopathy, tapetosubo cardiomyopathy, most of them heal up. They don't leave a damage. Pregnant woman can have that. If you are writing an NIH grant, you may have a stress-induced cardiomyopathy. Or one of my patients basically had, no, I'm not joking. One of my patients had came in, young guy, 36-year-old, that happened 2 weeks ago. And I said, I mean, he has this ST elevations, so I'm going to take him to angio. I said, what happened? He said, well, I started having chest pain, doc, and then we did his angiogram, all his vessels are open. And then when we did the left ventricular angiogram, it was like the reason they call it tapetosubo cardiomyopathy reminds me the calamari. Huh? Well, reminds what? Basically the octopus, right? It's like an octopus, the apical ballooning, right? So I said, what happened? Your coronaries are open. He said, well, I bought an expensive house, $5 million, and then I get another house, $3 million. And I said, well, you may think about selling one of these houses. Your heart pumping function will come back to normal when you do that, because what you have is stress-induced cardiomyopathy. Do they have damage in the heart? Yes. Do they heal up well? Yes. All right. So cancer patients have that too. 10% of the cancer patients ACS is that because they are worried, are they going to live? Are they going to get income, disability, etc.? And coronary hyperreactivity, endothelial dysfunction, and spasm, which we can find out. Imaging, imaging, imaging. I tell that to my fellows. I want them to understand the OCT. I want them to understand the iris. And Dr. Chen working on a catheter on iris and OCT, I believe is the future. And the problem is that you guys understand the OCT, you guys understand the images of the iris, but these layman donkey, you know, whatever you want to say, is the physicians are not understanding the images. They don't. And when they don't understand the images, they don't want to use the imaging to treat these patients. So I was in CRP meeting in Washington, D.C. 2-3 weeks ago, and there was a big group, imaging was full, and they said that only certain questions in our AVIM boards are related to imaging. They want more imaging. Now it has been shown that with iris use, the mortality in patients who are undergoing stenting goes down 60%. Why? Because you expanded the vessel wall. you have no stent thrombosis, you have, and that was one of the problems with the biodegradable stents, right? You have to use imaging, but I mean it in not a bad way, okay? I'm a clinician, but at the same time, I like to, dance on your side to understand what the hell we are doing as a clinicians. So if you implant the stent well, you don't end up with problems, as you can see right here. Well, what do you see here? What do you see in the iris image? What do you see in the OCT? I always love OCT, I'm sorry, because you get much better images. Unopposed stent struts. This is an underdeployed stent. This is just like it is just a thrombotic agent that's flowing inside the thing that the patient is going to have late stent thrombosis as soon as they start to do antiplatelet therapy. I had a lawyer who was basically in Cincinnati, and I was called in, and he had a late stent thrombosis because when I did the imaging, when OCT, I saw that his stent was floating inside the lumen. So these are very, very important, okay? FFR you can use to see the significance of a lesion, but I use OCT. I use the OCT to diagnose what the pathology is, and using the OCT, I can get the cross-sectional area on the and the minimal lumen area on the longitudinal pullback, and therefore I can see if it is going to be more than 70% lesion or not. So you can get all this information. You don't necessarily need an FFR. When PCI is indicated, we use POVA, meaning just balloon by itself, less than 30% if they do have platelet count. But if they are calcified, then then we are going to have the laser lithotripsy hopefully coming out of UC Irvine. And BMS, bare metal stents, we barely use them. But platelet count is, when the platelet count is more than 30,000, and elective surgery, patient is going to have breast cancer removal, and they have a critical lesion, you basically put a bare metal stent, and then image wood, and then we give them 4 weeks of antiplatelet therapy, and we tell the patient, yes, you can get your mastectomy now, okay? And then therefore, but use the imaging to make sure you have good stent extension. Third generation DES, fantastic results. We barely put bare metal stents in these patients. So after PCI, after we do the stent deployment, OCT iris is recommended to assure optimal apposition, vessel apposition, and absence of complications, such as distal edge dissection, geographic miss of the lesion, and then basically hematoma, intraluminal hematoma. So we need to train the clinicians in the cath lab to use more imaging to basically achieve much better results, particularly in cancer patients. There is no question about that in my mind. Special procedures in cancer patients, I don't want to bore you with that. So we no longer use the groin for right heart cath. I just access here, just regular needle, and then I use the multi-purpose catheter and go into the right side and get measurements and go. So stay away from the groin. Patients love it. I don't even basically bring the patient, I don't even ask my patients to take their clothes and stuff on the rest to get the scrub to go in. My patients basically come in, take their jacket off, they just lay down, get their ready and done. So patients love that, and they go to home the same day after the procedure. They can get restriction and constriction physiology because the pericardium, as radiation comes in, becomes thickened up, including steroid use, including chemotherapeutic agents. It becomes like a heart shell, and then you have vascular dysfunction. So we use 5 French catheters, and then we do the biopsy clamps, basically try to get some of the biopsies, especially for anthracycline. This is used in breast cancer patients. Basically, the level of evidence is high. Fulminant myocarditis can happen, and pericardiocentesis, cancer patients can get a lot of fluid around their heart. So instead of sending them to surgery, we just go ahead and use a specific technique. This is published also. It's a very, very useful technique, and we send them home the same day. I don't want to go in there. These are the problems that when we have problems, when we do the pericardial tap, pericardiocentesis, and these patients, so they don't just get vascular and heart defects. They do calcification of their aortic valve and mitral valve. So they basically get microstenosis, and they get aortic valve stenosis because of radiation. So I had a patient who came in who had, and Mark Feldman took care of it with me, so what happened is that patient had a colon cancer. He came with constipation. He had a colon cancer, and he has at the same time aortic valve stenosis. So which one do you treat? And so what we did is that as long as the patient has a survival of more than 1 year, we treat their aortic valve stenosis. So first, Mark has done in a close by hospital pulmonary aortic valve blood test. The patient went to surgery, get the colon cancer taken out. Then we go ahead and put on this patient a cover valve, which is with the Edward Life Sciences. Okay. This is our paper again. We do a lot of, we publish around 20 to 30 papers with MD Anderson on this point. So key points, cancer patients should be referred to CCL due to their atypical presentation, cardio-oncology service, ACS mortality and acceptable bleeding risk, no platelet threshold for a diagnostic test. We can do it in all patients. You don't have to worry. Aspirin, as I said, the numbers and the dual antiplatelet therapy, we know about that more. FFR before the stent OCT, they use FFR, I use OCT because I can see on the pullback, longitudinal pullback, where is the narrowing is. I can measure the MLD, I can measure the cross-section area in 3D, and then I can basically plot it out if it is more than 70% occlusion or not. And then pericardial drain, leave them in place, and then say patients who have cover, etc. Wait for 1 second for me. I want to show you some cases here, okay? This is, I'm no longer at the heart hospital, but these are actual patients that I did take care of these patients. And this is how we started. So let me go. So cardio-oncology in US alone, we went over that. So this is a patient, actual patient, 84-year-old Caucasian male referred for severe symptomatic aortic valve stenosis for transcatheter aortic valve replacement and or repair. So aortic valve area severe AS, patient has kidney problem. STS is score of what is this patient risk of dying in 30 days after the procedure? 16.5%. Anything for us in cardiology above 1% is a very high risk. So this patient is very, very high risk. So this is an echocardiogram. It shows the velocity. Anything above the 4 or 3.5 is severe. And then I come into echocardiogram here. This is left ventricle is sick. So LVEF is severely reduced. This is the aortic valve. So we go ahead and basically get the valve in. This patient has 2 cancers. This patient has a colon cancer. This patient at the same time has a bladder cancer. So he has an ileostomy tube, and at the same time he has a colostomy tube, etc. And we put the largest valve in this patient, and it is an evolute R valve. They go through the groin, and here is our wire, and even the wire is big technology, billions of dollars. So this is a self-expanding valve. We just brought it in. This is actual old case. We put the valve in. It's a self-expanding nickel titanium self-expanding metal mesh, and basically it has the thermal memory. And here is our aortic valve. The patient's ejection fraction gets better. Why? Because the obstruction has been, afterload has been removed. This is a lady, the actual patient that I told you, breast cancer, 61-year-old nurse practitioner working in the emergency room. Fantastic lady. Unfortunately, she had breast cancer. The anthracycline caused her LV to be myocardial. Anthracycline-induced myocardial dysfunction, cardiomyopathy. And surgeon said, I'm not going to operate on her. Her coronaries are open. So I went and put, she had a mitral valve, mitral regurgitation. Her ejection fraction is very low. Do you see this color here, blue? That is not supposed to be there, the mosaic. I call it mosaic color. This is severe MR coming into left atrium and pulmonary edema. So I went ahead, you see right there, it comes back to pulmonary veins. So I went ahead and do a mitra clip using the 3D TEE, and 3D TEE change how we navigate inside the heart. Amazing. It is just absolutely amazing technology. So we put a clip right there. We look at the gradient now to make sure that we did not create a stenosis. And then she has absolutely very nicely treated because color is gone. So her ejection fraction came back to normal. She went back to working in 3 months. She's back into working in her usual stuff. She's not only studying for it. This is a patient who has a high risk of thrombosis, who has atrial fibrillation, and he has bleeding, and he has prostate cancer. And so we use the Watchman device. The Watchman, so clot, what happens here? 90% of the AFib, the clot happens in the left atrial appendage. He has a hypercoagulable state because of cancer. He is elderly. He has a high risk of bleeding. He requires 2 units of blood. I use the 3D TEE, beautifully plot that, the ostium, you can see right here, 33 millimeter device, and here it is closed. 45 days, it basically the tissue covers it, and it heals. He no longer has to take blood therapy, and he did not have stroke. With that, I will conclude. I thank you very, very much. I have had chance and pleasure and honor meeting Dr. Chen and some other collaborators. I will tell you this, I'm very honored to be here. There's a lot of research we can collaborate together. I would love to be part of you and collaborate with you and make a center of excellence for cardiovascular research and innovation here with the leader or leader, Professor Dr. Tom Miller. Thank you.
Mehmet, could you talk about a little more about using OCT and sort of pre-imaging and post-imaging? When you're doing, say, putting in a stent, do you usually image before, or you usually just image afterwards? Exactly, what are some details of how you're using OCT in relation to stent?
So that's a very good question. So most of the people for the time frame, they just pull the OCT catheter and they want to see their justification and they want to see the stent expansion. So they do after. But I like to do before, because that's going to tell you the last thing you don't want is stent not expanding because of calcium. So sometimes the fluoroscopy, the conventional X-ray, is very, very poor in identification of calcium and quantification of calcium. So if I will use the OCT, Tom, I'm going to open up the device anyhow. I open it from the beginning. And usually we try not to use contrast. We use dextran as well. But if you use contrast, that's fine. Current technology is so much advanced, does a very good pullback, a long pullback in a short period of time. So I want to see if it is a plaque erosion, and then if what kind of plaque is that? Is that an eccentric lesion behind the plaque, right? Sometimes you have the plaque, but you see the plaque, but behind the plaque you have a necrotic core and calcium, and then when you try to expand the stent, it kind of sandwiches itself and expands, it cuts through the tissue, and these small particles, calcium particles, go down drain, and you have no reflow. So I like to use the OCT right from the beginning to understand what is exactly going on. It also gives me a reference diameter, proximal and distal reference diameter, so I know what leg size I'm going to use to exactly. How much of the stent am I going to use? What length instead of stenting the normal vessel? And what reference size am I going to use? And to make sure that I will not have 5 millimeters from each end of the stent, that I'm not going to have geographic miss, putting a second. Usually you want to put one stent, not overlap, because if you overlap, you will have too much of the medication that prevents the vessel, and that has adverse effects. So I use it before, and of course I use it after. But most people use it after, which doesn't make sense to me, because then you're using your eyeball to get the stent length. You may be stenting longer than you need or shorter than you need. So just use it from the beginning. So cancer, cardio-oncology is going amazing. I don't know if you have a section here. You probably, you have a cardiology subspecialty. It came out 20 years ago. It came out from MD Anderson. Now there is cardio-oncology fellowships in the United States, and I think it should be, because more people are living with cancer, and their, as you saw, as I showed you, is their treatment is not routine. I want to go to a cardio-oncologist, not a regular cardiologist.
Maybe I can follow what Tom asked. What happens if you find it's not fully stand or afterwards? Is there a way you can redo it?
Yeah, very good question. So let's say that the OCT image that I showed you, that this is the vessel and this is the floating stent. I basically make sure that I don't lose my wire position because I don't want that stent to, I don't want to deploy that stent down on the stream. I want to deploy it where it's supposed to be. So we basically use non-compliant balloon. So I bring it as it is deflated, original shape, because once you inflate the balloon, it no longer will go easy. So I open an original balloon, I go undersize the bit, I want to release the radial force first, and then I want to go 1-to-1 size or 1-to-1-1, and then deploy that stent over. But your question is very good. The thing is that can you expand a 2.5 stent that you thought it is 2.5 because you didn't use the OCT before as a reference? Can you expand it stent thrust to 3 mm stent? I don't think so, because there is so much stretch that you can gain in that compliant. That's why I want to use the OCT right at the beginning, not later. And you have to have that so that you don't have stent thrombosis, you don't have other issues.
Like currently, what's the penetration in the market? Like how many percent of interventional cardiology before they put the stent, they do this image?
They do very nice. They usually say that IVUS or OCT, 30%. Can you believe that? 30%. But use of OCT, even less. And that's a shame. Because, no, let me ask, this is the last question. How many of you want a doctor, clinician, we are not smart, to use fluoroscopy and angiography to predict the stent size and put it? And how many of you want an imaging-guided stent deployment? So the first one is angio, for angio, like old redneck style. So do you want that? Raise your hand. How many? I don't mean to be abrasive.
Yeah, too young to worry
And how many of you want imaging guidance? Yeah, I mean, it's no brainer.
So why, because we've seen, many, and the studies are coming out, like even with IVUS, the outcomes are much better.
Yes, no question.
Right, so is it a payment issue? Why? Because it seems clear that the data shows outcomes are better if you do the imaging.
I don't have money, and I'm not a money-driven guy, but most of the physicians want to do more cases. They want to be done. They don't have patience. That's number one.
It takes too long.
I don't think it takes too long. You know how fast it is. Laziness. The second thing is that there is Germans, which some of you know here because of your interest, is in Washington Heart in DC. And he is even saying that we need to basically not create, graduate plumbers. We need to create, graduate people who understands OCT. That's why VHOCT is very important because they don't look at, they look at OCT, which what is this here? Calcium or lipid core. I guarantee you get 10 interventions here. 9 of them will not know the difference. So if you don't know, you don't want to use. But if you know, I bet you anything, if you ask them, Tom, they will want their stent to be deployed by imaging. Now, I am against the one thing. There is one crazy guy I know, I will not name him. He uses the IVUS, not much OCT, and he stents the hell out of your arteries, saying that you have plaque here and plaque here. I am against that. I mean, don't use the imaging to overdrive the, how much disease you have, but use the imaging right. And I think the program changes is coming now in physicians for fellows, clinicians to graduate. You have to get X number of imaging, and you need to understand. And we will ask you. I just get an invitation from American Board of Internal Medicine, and I was getting to talk. They want me to be on the writing committee. What do you think will be the topic that I will write for question writing in interventional cardiology? I love OCT. It will be OCT or IVUS.
Is there any like a survey like whether the young clinician more adapt to new technology
Very good
compared
question.
to the.
I'm going to ask that to Scott. There is some surveys that are done that because some of them really interventionists, they really want to, they are wonderful people and they want to know what they are doing. They want good outcome, not just the plumb the, stand and get $10,000 from whatever patient and all this stuff. Yes.
So we understand the advantage of image-guided placement of stents. Is there a prospective study to compare one arm image-guided, another arm just regular?
Has been done, many of them. And the most recent one from Washington DC, CRT meeting showed 60%, 40 to 60% reduction in mortality, risk of death. So I don't think that anybody should argue, 2 and 2 is 4, right? I mean, so I conclude with one last thing. Believe me, this will be the last. Why I believe in OCT. None of the technology today we have tells you which plaque is going to rupture. Number one, do you have a plaque that's supposed to rupture? There is nothing. Oh, I had a stress test. Stress test only tells you if you have severe stenosis. It doesn't tell you if you have 40, 50% stenosis that's going to rupture. Now we are going to travel to Mars. There's no shortcut. Pilot, MEHMET, have a heart attack. Let's go back to Earth, UCI, and get a heart cath. So how the hell you are going to say that? Because astronauts have 5 times higher risk of heart attack because of radiation on space and etc. and forces and etc. And they get mutation. And the thing is that I strongly believe when I was an internist, there was a colon angiogram, margin for colon cancer detection. It was telling you, yeah, you have a polyp. Okay, that's fine. I want to know if it is malignant or not. And now, even that time, I was sending patients for colonoscopy. What do we do now for colon screening? Everybody above 45 needs to get colonoscopy. I got mine twice. And then they find polyps and they remove it. Then the thing that when I say that in the meetings that people say, oh, everybody has plaque. We know that. And most people who have colonoscopy have polyps, right? But the question is, some of these polyps do turn to cancer. So I believe that in the next 5 to 10 years, if the right studies are done by NIH, OCT will be used in patients who are high risk for OCT pullback from 3 coronary arteries because the plaque ruptures in the first 30 millimeters, okay? Even in females now. We will know where the plaque is. We will develop a fantastic, I love your algorithm. That is the TICFA. Then the second one is macrophages. And the third one is elasthroscopy, okay, with OCT. And you create an artificial intelligence algorithm, and you say, you know what, Mrs. X, yes, you will have a heart attack. And guess what? We are going to diagnose it now, but we will treat it with OCT. We will use the laser to thicken up the TICFA and kill the macrophages. That is why I believe. That's it. Thank you.
Okay, thank you.
Thank you, Tom. Anybody on the Zoom has questions? I'm happy to answer.
Any questions from Zoom? Okay,
Thank you.
thank you.
Thank you for coming, everybody.